All right, welcome. Today we're doing a focused briefing on yellow fever, especially for those of you in the Dutch context. Some diseases are just a flat-out race against time, and yellow fever is definitely one of them. Now, all the information we're covering today was pulled together using a Gemini deep search, and if you want to check out the sources for yourself, they're all listed in the Notebook LM document we've linked. So let's jump right in. So I want to start with a number, a really important one. When you have a patient with yellow fever in front of you, how many specific licensed antiviral therapies are in your toolbox? The answer is 0. None. And that stark reality is why everything else we're about to talk about, from diagnostics to supportive care, is so incredibly important. Okay, so with no specific treatment on the table, our best weapon is knowledge, and that means we have to start with the pathogen itself. Let's get into the nitty-gritty of the virus. So, yellow fever virus, it's a member of the Flaviviridae family, in the Flavivirus genus. Think of it this way. It's in the same notorious family as dengue, Zika, and West Nile. And that's not just, a fun fact for a textbook. Being part of this family has some really big implications for diagnostics, which, believe me, we are definitely going to get into. And if we zoom in on the virion itself, it's pretty much a classic flavivirus. You've got an envelope, an icosahedral nucleocapsid, and it's tiny, about 50 to 60 nanometers across. It's just a really neat, efficient little package designed to cause a whole lot of trouble. Okay, so we've seen the virus. Now let's talk about the clinical confrontation. What happens when this thing gets into a person? Understanding how the disease progresses is absolutely key, not just for the clinicians, but for us in the lab too. The thing about yellow fever is that it's notoriously biphasic, which is what makes it so tricky. You get this first acute phase. High fever, terrible headache, back pain. Then things seem to get better. The patient enters a period of remission. And this is the really dangerous part, because for some, this isn't recovery. It's the calm before a massive storm, the toxic phase. And during that initial acute phase, there's a classic clinical sign to look out for, Faget sign. Basically, you have a patient with a raging fever, but their pulse is paradoxically slow. It's that dissociation. High fever, slow pulse. That's a huge red flag and should make you think yellow fever right away. And for those patients who do enter that toxic phase, we're talking jaundice, hemorrhage, multi-organ failure, the numbers are just awful. The case fatality rate jumps to a staggering 30 to 60%. It's a brutal reminder of just how destructive this virus can be. So let's put it all together. No specific treatment, a really high mortality rate for severe cases. This means that rapid, accurate diagnosis isn't just helpful, it's the most powerful intervention we have. This is where we, in the lab, become absolutely central to the whole story. Okay, first things first, and I want to be crystal clear about this. Viral culture is not the way to go for primary diagnosis. If you're looking for a fast, reliable answer to guide clinical decisions, culture is not your friend here. And here's why. The wild-type virus you get from a patient often just doesn't like growing in our standard lab cell lines. It's not adapted to them. So what happens? It might be there, but it won't produce any of that classic cytopathic effect, or CPE, that we look for. You'll get a false negative. So let me repeat. A negative culture means absolutely nothing. It does not rule out yellow fever. So what should you be doing? In that acute viremic phase, it's all about molecular. RT-PCR is the gold standard, hands down. It's fast, it's sensitive, it's specific, it's everything you need to make a real difference for that patient. Now let's talk serology, because this is where things get really messy. The big problem, as this quote points out, is massive cross-reactivity with other flaviviruses. You get a positive IgM back, what does it mean? Is it yellow fever, or is it dengue, or Zika, or maybe they were just vaccinated a while back? It's a huge pitfall, especially for travelers returning to the Netherlands, and it's precisely why molecular testing in that acute phase is so non-negotiable. Okay, so we've established how to diagnose it. Let's pivot now to management and prevention, and look specifically at how this all fits within the Dutch framework. And what you see here is that, thankfully, everyone is on the same page. Whether you look at the Dutch LCI/RIVM guidelines or international ones from the WHO and CDC, the story is identical. The therapeutic approach is supportive care only. That's it. And there's one massive contraindication to remember: no NSAIDs, no aspirin. They can worsen the bleeding risk, which is already a huge concern. So what about antiviral resistance? This is probably the easiest slide of the whole presentation. The concept is clinically irrelevant for yellow fever. Why?
Well, you can't develop resistance to a drug that doesn't exist.
Prevention really comes down to the vaccine. But when we're talking about kids, you have to be incredibly careful. The rules are strict for a reason. For infants under 6 months old, the live attenuated vaccine is an absolute no-go. The risk of encephalitis is just too high. Then you have this gray zone, from 6 to 8 months old, where it's not recommended unless travel to a risk area is completely unavoidable. After 9 months, it's routinely recommended for children heading to those areas. So this all leads to a pretty big question for us, right? It's easy to think of yellow fever as something, well, historical, from another century. But let's be real, global travel is back in a big way, and the ranges of mosquito vectors are expanding. So is this 17th century virus actually a very real 21st century threat for us here in Europe? And that's where we'll leave it for today. I really hope this briefing on yellow fever was useful for you. If it was, hey, please consider subscribing for more deep dives like this one. And I really do want to hear from you, so please drop your questions and feedback down in the comments. Thanks so much for your time.